Hello, everybody. Welcome to Pediatric Grand Rounds. I'm really delighted. Today we have one of our Frontiers in Child Health Research seminars, and I'm delighted to introduce our speaker, Dr. Mary Karalius. Did I say that right?
Karalius, yeah.
Karalius, who's our speaker for today. Dr. Karalius is a child neurologist and immunologist here at UCSF who did her training with us, I just learned. And she leads an NIH-supported research program to advance genomic tools to develop immune signatures that can better distinguish between autoimmune and infectious encephalitis. The work she does grew directly out of her clinical experience caring for patients with unexplained brain inflammation. Today, she'll share emerging advances in diagnostics and therapeutics that are improving our ability to identify and treat pediatric neuroinflammatory conditions. So please join me in welcoming Dr. Karalius.
Let's see. Thank you all so much for having me. It's a pleasure to be here, and I'm really excited to talk to you today about pediatric neuroinflammatory conditions and share some recent updates in the field. So thank you so much for having me. These are the learning objectives. So hopefully by the end of the talk, you'll be able to recognize a couple of key neuroinflammatory conditions and their clinical presentations. I hope you'll be able to describe some of the emerging lab-based diagnostics to help support earlier diagnosis of these conditions, and then understand some of the standard treatments we're using, as well as some of the novel therapeutic agents down the pipeline. And in general, really hope that you'll take away just a couple of pearls that will help you think about children with neuroinflammatory diseases a little bit differently. So I will start with a case. So this was a 4-year-old male, previously healthy, no past medical history, who presented to our ER with some behavioral changes and abnormal movements for the prior 5 days. Mom said it started with some sleep disturbance, wasn't sure if he was just going through a regression or what was kind of going on, but eventually was hardly sleeping at all. He also was more tearful, inconsolable, irritable, which was pretty atypical for her normal sort of happy 4-year-old. And then he developed what Mom described as kind of wiggly movements of the arms and the legs. And then she noticed some sort of abnormal mouth movements. So kind of some like tongue thrusting movements, lip smacking that she thought was really odd. And then his speech started to decline where he stopped talking, which really prompted her to get him evaluated in our ER. So in the ED, his exam was most notable for an abnormal mental status. So he was not following commands, was really not talking. And then his motor exam was also pretty significant, where while he was moving all of his limbs anti-gravity, he did have kind of these, what we would describe as hyperkinetic, non-stereotyped movements of his arms and his legs. And then we also noticed sort of this occasional, kind of like what Mom was describing, abnormal tongue thrusting, and what we would describe as oral buccal dyskinetic movements. So some lip smacking, some jaw clenching, so sort of very atypical. And then he also had some mild truncal ataxia when trying to sit up. And so to us, this was a pretty concerning exam. He was having sort of altered mental status with encephalopathy, as well as a new movement disorder in the setting of some acute behavioral regressions. So concerning to us. And so if wanted to pose, I wish there were some more trainees here. I was going to ask the trainees what their opinion would be. But I don't know if there's any trainees on the Zoom, but sort of if you're seeing this kid in the ED, what are some things you're thinking about, and what are some next tests that you would want to consider ordering?
I'm GI, so I'm going to say get pneumonia.
Get a pneumonia. Okay, I like it. I like that. Other things.
ICU doctors, we're going to say imaging.
Imaging, exactly. Perfect. Other thoughts, things you're thinking about on the differential?
Well, we're decent test takers, so I think probably going to want an LP and some.
No, what?
See.
An LP, exactly. Okay, you guys nailed it. Great. So this prompted us to, again, recommend kind of our classic neurologic workup. So if you're consulting us, usually we're going to ask about MRI, an LP, and an EEG. So his basic, and then plus or minus some serum labs. So his serum labs were normal. His brain MRI and total spine, his brain and total spine without contrast were normal. His lumbar puncture was abnormal with 22 whites, predominantly lymphocytes, normal protein, normal glucose, rapid HSV1 was negative. Some of the other autoimmune tests were still pending. And his EEG showed mild, diffuse, continuous slowing, but no epileptiform seizures or discharges. So with this additional workup, more worried, less worried about a potential autoimmune inflammatory process, more worried. Yes, we were also worried. We were worried to the point where we felt like even without sort of a definite diagnosis, given the positive LP, the abnormal EEG, his altered mental status and new movement disorder, in the absence of really any strong infectious risk factors like concerns for acute meningitis, things like that, we did want to go forward with empiric treatment. So we treated him, again, what our routine is for concerns, kind of first line for an autoimmune inflammatory process with IV corticosteroids for 5 days, followed by IVIG. And we typically do 2 grams divided over 2 days. Sure enough, his NMDA antibody came back positive. And so for us, this was, again, pretty classic case of anti-NMDA, previously healthy kid, kind of subacute, acute onset of some altered mental status, disturbed sleep, new onset movement disorder, and then findings on LP with lymphocytic pleocytosis and some abnormal EEG. So again, kind of hoping to frame kind of classic NMDA. So let's take a step back and talk a little bit more about autoimmune encephalitis. So it's really just inflammation of the brain, so an itis due to an underlying abnormal immune response to the central nervous system. It's pretty rare, but I'm sure many of you guys have seen several of these cases already. And for the trainees, you probably will see some in your career. Even though it's rare, there are relatively high rates of morbidity associated with encephalitis, as well as mortality up to 15%. So this is oftentimes lower in our pediatric patients and depends on the exact antibody that's detected. And then 40% of cases present before the age of 18. So definitely something that we're seeing in our pediatric patients. Neurologic presentations can be super variable and can really impact any neurologic domain. So it can kind of start with sort of altered mental status and confusion, disturbed sleep as our patient had. And oftentimes this is a symptom that can be missed if you're not asking for it. Movement disorder, seizures that can be multifocal, can be generalized, can be purely focal. There can be cognitive and behavioral changes, and then a wide range of psychiatric symptoms ranging from mood swings, mild personality changes to fulminant psychosis, especially in NMDA. And then does anyone know which one of these movement disorders is really sort of classic for NMDA? Again, this was a question for the trainees. All right, well, the orbital dyskinesia is definitely, if you're seeing this in a kid, the mouth movements, lip smacking, jaw clenching, like weird sort of mouth movements, you definitely want to think of NMDA encephalitis. There are several risk factors for autoimmune encephalitis. So these are things you can think about if you're taking the history of a patient with concern for autoimmune encephalitis. So definitely coexisting autoimmune diseases. So things like thyroid disease, type 1 diabetes, lupus can co-occur. Malignancy is pretty common too, more so in the adult patients where we have a lot of paraneoplastic autoantibody disorders. But in our younger patients with NMDA, we know that ovarian teratomas are very common. So up to 60% of our female patients with NMDA will have an ovarian teratoma associated with it. So you'll oftentimes hear us recommending CT abdomen pelvis or an ovarian ultrasound to see if there is an ovarian teratoma, because oftentimes removal of this improves symptoms. And so definitely important to think about that. Environmental or viral triggers. Again, about half of kids will present with sort of this prodromal fever, sort of suggesting that there's likely a post-infectious immune-mediated process. And then family history can also kind of clue you in. We don't obviously have one gene that we think causes or predisposes to autoimmune encephalitis, likely multifactorial, but definitely something to ask about in terms of family history. While historically infectious encephalitis was thought to be the most common cause of encephalitis, we now know that autoimmune encephalitis is likely as common, as shown here, where you can see that the incidence of autoimmune encephalitis has increased over time. So the light bar is from 2006 to 2015, and then the dark bar is prior to that. So you can see sort of an increase, whereas in the incidence of infectious encephalitis has remained about the same. This is likely due to a couple different reasons. One, increasing recognition. So many of you may be familiar with Brain on Fire, and if not, I would highly recommend reading this book. Turns out it's also a great gift for a neuroimmunologist to give their mother-in-law at Christmas to help them understand what you do on a regular basis. But it's told from the point of view of a patient who developed anti-NMDA receptor encephalitis, and it really put NMDA on the map, and kind of highlighted how there were many cases of new onset psychosis in particular that were being misdiagnosed as a primary psychiatric disorder, when in fact these patients actually had an autoimmune encephalitis. So again, definitely worth the read. There's also a Netflix movie as well. So if you're not a big reader, you can also watch the movie or series on Netflix. Additionally, from a laboratory side of things, there's many new technologies that have been developed over time to help us better diagnose autoimmune encephalitis. One that's commonly done here is phage immunoprecipitation sequencing, or FIP-seq. The details are probably out of the scope for the talk, but it's basically a high throughput method that allows for detection of sort of unbiased novel antibodies. So if you hear us talking about sending for sort of novel antibody discovery, this is kind of one of the methods that we use in the lab to do that. Here you can really just see the rapid growth of autoantibody detection over the last 10 years. And so really kind of shows how the field has been able to identify more and more autoantibodies that are associated largely with clinical syndromes. Despite this, I still want to highlight that up to half of cases, maybe a little bit less, still remain idiopathic. So as a group, we definitely have lots of work to do in terms of still kind of figuring out the causes of in these idiopathic cases. So what do I do if I think I have a case of autoimmune encephalitis? Good news, there's now 2 really great guidelines that have been published, one in adults, and then like most pediatric things, the guidelines were adopted to pediatric patients in 2020. And so I always find this guideline super helpful with even at this stage in my career to look back and kind of review if we're getting consulted on a case for autoimmune encephalitis. It really nicely outlines the differential diagnosis, the recommendations for workup, and then classification into sort of definite, probable, or possible antibody-mediated encephalitis. So I always find that really helpful. It really also nicely outlines the differential diagnosis, which is pretty broad. And so when we think about a kid coming into the ED with a concern for encephalitis, we really need to think very broadly about all the different possibilities shown here, particularly in our younger pediatric patients. We have to think a lot about metabolic and genetic diseases, demyelinating diseases. So a common mimicker can be MOG, which I'll talk about in a little bit. Psychiatric is huge. We get a lot of consults for new onset psychosis, and so that's definitely something to keep in mind. And then infection, which I'll also talk a little bit more about, and kind of how we can better distinguish between infectious and autoimmune encephalitis. And then just more like systemic inflammatory conditions, vasculitis, those are definitely less common in peds. Same with neoplastic, fortunately. And then in our teenagers, always have to think about toxic kind of metabolic. Like I mentioned, if you're calling us for a consult for a concern for an inflammatory process, we're likely going to ask about the following things. So serum labs, kind of depends on case by case, but if there's a concern for an infection, we'll recommend some targeted infectious testing. And then if there's concern for sort of potentially systemic autoimmune rheumatologic condition, we'll oftentimes recommend sending sort of ANA or lupus markers, things like that, but usually less high yield. Really where the money is the brain, MRI with and without contrast. If there's concerns on exam, we'll often recommend spinal imaging, lumbar puncture. Usually we'll send for cell count, protein, glucose, bands and index. So we know that sometimes can take time to come back. So not always helpful in the acute setting. The autoimmune encephalopathy panel, HSV, PCRs, which come back very quickly, the infectious meningitis encephalitis panels, and then NMGS or metagenomic next generation sequencing, which I'll also talk about in a little bit. EEG can be really helpful. And then urine studies, like I mentioned, if we're worried more about a toxic syndrome, we can get a UTOX, and then full body imaging as well. Like I mentioned, if we're really highly concerned for something like NMDA or perineoplastic etiology, we'll oftentimes recommend additional body imaging, including, and I should have put on there, ovarian ultrasound. Okay, so in terms of what antibodies you might actually detect and what we're really seeing. This is a study that specifically looked at children with suspected antibody-mediated encephalitis, and it showed that the majority of children were positive for anti-NMDA, with the second most common antigen being MOG. So in your careers, if you haven't seen a case, trainees, you likely will see a case of autoimmune encephalitis, and by and large, it's likely going to be an NMDA case. Many of the other ones are much less rare. A couple of key pearls about NMDA. I already mentioned that a movement disorder can be underlying clue. A normal MRI can also fool some people. So specifically in anti-NMDA, MRIs can be normal. And this can actually be a hint towards thinking more about NMDA as opposed to some of our other autoimmune encephalitis like GFAP or GAD65, which can have more often abnormal MRIs. If an MRI is abnormal, usually you'll see sort of flare hyperintensities in the hippocampus or temporal lesions, especially if they're having seizures. And this oftentimes actually portends a worse prognosis. So definitely something to keep in mind. And then I really like this graphic because it really highlights the time course of NMDA along with key symptoms. So it does oftentimes start with kind of viral prodrome, and then patients may start to develop sort of subtle psychiatric symptoms, but eventually it can really progress over the course of weeks into more serious symptoms like refractory seizures, autonomic dysfunction, severe movement disorders. And so for the PICU people in here, I'm sure you guys have all cared for some of these patients in the ICU where they end up needing lots of drips and sedatives for their agitation, for psychiatric symptoms. They also may be having frequent seizures, will need control of their movement disorders. So again, just kind of highlighting how it can really impact many neurologic domains. I also tend to kind of talk to families and let them know that even if we initiate treatment early, oftentimes these symptoms can get worse before they get a little bit better. And so it can be kind of feel like a waiting game where you're like waiting and waiting for some improvement. And really it can take weeks to months to really kind of get through the kind of acute period where you're really sort of managing their seizures, their autonomic stability. And so really trying to like set expectations with the family ahead of time, I found to be really important. And then even in the outpatient setting, when we see these kids, we know that there can be prolonged recovery, ongoing deficits, including memory deficits, disinhibition, attention problems, and that can last several years. So again, just kind of trying to highlight that, that this can be a pretty long course. Nonetheless, in general, patients actually do really well. So some studies suggest that up to 70% of kids actually make a complete recovery. 20% will have some level of behavioral and school working deficits. They'll need IEPs, 504 plans. And then in a minority of patients, they'll really struggle with multi-domain deficits. So we'll have more significant cognitive impairment, maybe ongoing epilepsy, and really kind of fall into, again, kind of have more struggles and will need more support. If you're younger at age of onset, you're at a particularly higher risk of falling into this category. So definitely something to think about in terms of if you're caring for a younger kid in particular, to kind of think for that this kid may need a little bit more support in the outpatient setting. I also want to emphasize that we're learning more and more that earlier treatment does improve outcomes. So this study looked at initiation of first-line therapy, so IVIG or steroids, initiated at 2 weeks versus 3 weeks. And even if you're able to get these meds into these patients by 2 weeks, they do better than 3 weeks. And I think now we actually are even better at this and can get the meds in them sooner, which is great. But just emphasizing how it's super important to have a high clinical suspicion for this and to get treatment started as soon as possible. This is the second paper that for the trainees to bookmark and to keep in their back pocket. So it basically is the consensus guidelines for treatment of anti-NMDA encephalitis, and this can be also applied to other types of encephalitis. I'll walk you through some of the recommendations with the caveat that, each case is a little bit different and these are just guidelines, but in general, again, it's really great because it not only gives you kind of first, second, third line, but also gives you the dosages. So if you're talking to pharmacy and they're like, what dose do you want to give? I always still reference this paper in particular. First line treatment, like our patient got IV corticosteroids, IVIG, and sometimes escalation to Plex. In head-to-head IVIG versus Plex, there's not really one that has shown to be more effective than the other. Typically, we think Plex maybe works a little bit faster, but it comes with the risk of needing to place a line. And so oftentimes we're usually just reaching for steroids and IVIG. And then some patients will need prolonged first-line therapy, usually for about 6 months. Usually we do IVIG, and that's in cases that are more severe. In terms of second line, we usually recommend rituximab or cyclophosphamide with a slight preference for rituximab, given more favorable side effect profile. And we usually kind of jump to this if there's no clinical improvement within about 2 weeks. That being said, 2 weeks can feel like a really long time. And so oftentimes if we have a really high suspicion, we're jumping to these treatments sooner than 2 weeks, but just acknowledging that the guidelines, again, and thinking back to the graph in terms of like how long the process can be, the guidelines really suggest waiting 2 weeks. And then if they're still not getting better, we will either do the alternative. So if we gave rituximab, we'll give Cytoxan, or if we gave Cytoxan, we'll give rituximab. So that's one option. And more often now, we're actually leaning on medications like tocilizumab, so an IL-6 blocker, which I will talk a little bit more about, but definitely sort of a newer agent that you may hear us like talking a little bit more about. Okay, so that was a little bit background on anti-NMDA and some key pearls. I'll now spend some time talking about MOG, because this is also probably something that you guys will all see in your career. You'll see it on the wards. You may have a patient in your outpatient clinic that's had a history of MOG. So again, just we'll talk a little bit about what MOG is. We know that it's a component of myelin and it's expressed on oligodendrocytes. It's thought to act as a cell adhesion molecule, maybe regulating microtubule stability, maybe modulating myelin immune interactions. Lots of hand waving here because I don't think we still exactly know what MOG is or how it causes disease. We do know that it is kind of a demyelinating syndrome. And so because of this, many cases actually were misdiagnosed as MS or multiple sclerosis, which is kind of our classic demyelinating disorder. However, with the improvement in all of our diagnostic capabilities, most notably advancement in our cell-based assays, we actually now know that MOG is very different than MS. And when they went back and looked up tons of kids that were diagnosed with MS, there was a subset of patients that ended up testing positive for MOG, and looking at their clinical phenotypes and their MRIs, they actually were very different than what we typically think of as MS. We do oftentimes see a higher percentage of MOGAD in children, so definitely more of a pediatric disease. likely related to an immune response following viral infections, but again, this is not fully established. The most common pediatric presentation is ADEM, or acute disseminated encephalomyelitis. This is in and of itself kind of a clinical syndrome that presents with MRIs that look like this, so kind of fluffy, very fluffy, bilateral lesions, poorly demarcated. So very different than the NMDA, which I said it was normal MRIs, and then different than MS, where we typically see, if you remember back to med school, the discrete lesions, Dawson's fingers. So this MRI looks, pretty different than what we would typically see with MS. You can also get optic neuritis. It's often bilateral and can be associated with disc edema and elevated ICP. So sometimes these kids will actually present with headaches, and ultimately you tap them and they're found to have elevated opening pressure. And then the optic neuritis, again, can be bilateral, which also can be a clue, whereas in other demyelinating diseases like MS, it's usually unilateral. And then you can get longitudinally extensive transverse myelitis as well. So again, it can really impact any part of the nervous system, but ADEM definitely most common. This is the diagnostic criteria, which again is kind of based on core clinical demyelinating events, like I mentioned, optic neuritis, myelitis, ADEM, a positive serum MOG test. So this is one thing where normally we are all about the CSF, but in MOG, the serum is actually more reliable. And so really trying to think about ordering it, just a serum, basic serum MOG test. And then you also have kind of the supporting clinical features, like I mentioned before. So the optic neuritis, myelitis, being more longitudinally extensive as opposed to short segment. So yeah, this is, again, also a helpful resource when you're thinking about, like, does this patient actually meet criteria for MOG? One thing that's coming down the pipeline more often is thinking about actually MOG in the CSF. And so this testing, as I mentioned, by and large, we're going to have positive in the blood. However, there have been more and more reports of clinical phenotypes and syndromes that we're like super convinced are MOG. We test our serum again, negative, negative, negative. But then we actually can test our CSF, and MOG ends up being positive in the CSF. So again, this is rare. I would say probably less than 5%. Like I think we have maybe 1 or 2 patients in our clinic with this, where serum negative, CSF positive. And it's the CSF test. While I think it's maybe now offered by ARUP, it's still mostly on a research basis. So we actually end up having to go through Mayo Clinic, and they will run the test if we otherwise send them an autoimmune encephalopathy panel and they have extra CSF. So sometimes you may hear us say a serum MOG's negative, but we really still want to look. We still really think that this is consistent with MOGAD. Like we'll try to add on CSF testing, and that's something we kind of do on the back end. Early literature is saying that perhaps the CSF predominant serum negative cases are maybe have a little bit worse prognosis, but I think we still need to do a little bit more research in that area. And again, it's tough because we don't always send for CSF MOG, so the numbers of patients that are serum positive and CSF positive, again, it's a little bit unknown. This is another newer entity. So MOG can present kind of as more of a focal cortical encephalitis. So if you're seeing this MRI, definitely think have MOG on your differential. There's still a lot of unanswered questions when we think about MOG, so namely whether it's going to be monophasic or polyphasic. So this is a little bit different than MS, where we know that that's a chronic disease. Patients need to be on treatment. Only about a quarter of kids, maybe a little bit more, will present kind of with the polyphasic course, meaning they'll relapse. Usually, if they are going to relapse, it's within the first year, typically within the first 3 years, but lots of research out there looking at if there's a biomarker that could help us understand which kids are going to relapse and which kids aren't. So we've looked at persistence of MOG titer, level of the titer, age, sex, ethnicity, initial phenotype, MRI findings, and there hasn't been really one consistent study that's been like, okay, if the kid has this, they're going to definitely relapse. And this really is important when you're thinking about whether or not you're going to put these kids on maintenance therapy. And again, some kids present with one-time monophasic ADEM, completely recovered, do great. Other kids really will maybe present with an ADEM, then 8 months later, they'll come back with an optic neuritis and they'll come back with the so it definitely seems to be separation, but we still don't quite know how to predict which group a kid is going to fall into. We do acutely treat these kids with high dose steroids and IVIG, and steroid responsiveness can be a clue to a diagnosis. So unlike some of our other diseases, we give, if a kid has MOGAD, we give steroids, and actually like within days they're feeling better, their vision's improved. If it's an optic neuritis, so definitely a clue to a diagnosis of MOG. And then in terms of maintenance immunotherapy, it really honestly depends on like benefit discussion with families. If a kid really presents severely, they don't completely recover, or definitely if they have a relapse, we're putting kids likely on sort of chronic maintenance immunotherapy. Usually we reach for IVIG, sometimes rituximab, Cellcept, or azathioprine have commonly been what we've used. But satralizumab is kind of new kid on the blocks. IL-6 blocker similar to the tocilizumab that I mentioned for anti-NMDA receptor encephalitis, and we think that that IL-6 T cells do have a role in MOGAD as well as other neuroinflammatory diseases, and so targeting that with medications like satralizumab or tocilizumab there's increasing evidence to suggest that it actually may be pretty effective. These medications, so again, satralizumab, tocilizumab, historically have been used for neuromyelitis optica spectrum disorder, also used a lot in the rheumatology world, less historically used for other sorts of neuroinflammatory disorders, but there have been 3 recent clinical trials that are ongoing that actually are studying this. One in MOGAD with recent results that were just presented at the last neurology conference that actually said that satralizumab really does decrease the rates of relapse and relapsing MOG. There's also clinical trials looking at tocilizumab versus anakinra and new onset refractory status epilepticus or FIRES. So if we have a patient now with NORS FIRES, we're definitely sort of reaching sooner for tocilizumab, and then also some increasing evidence to suggest that tocilizumab may actually also be effective in NMDA receptor encephalitis and LGI1 encephalitis, which is adult onset encephalitis. So definitely kind of exciting. The MOGAD study actually included kids greater than 12, so some pediatric data there, and then the NMDA trial also included kids, some I think teenagers maybe, but nonetheless, in case series, this was a recent one that just came out of CHOP that looked at the use of tocilizumab in a wide range of neuroinflammatory conditions, including severe MOGAD, acute necrotizing encephalitis, idiopathic ADEM. Kids on tocilizumab actually did pretty well. So you probably will start hearing from us recommending using one of these agents. I think actually in the last, I don't see anyone who's on service right now, but we had 2 cases in the last couple of weeks where we were recommending tocilizumab alone. So I think that definitely something we're going to start using more often. Okay, I'll take a pause there. Any questions before I go on to next section? Yes.
I have a question for this. For area disease and maybe broadly pediatrics. So you're describing work in a set of rare diseases.
Yes.
And you're describing exciting new therapies. How do you balance, or how does the desire to generate robust data using clinical trials with sort of the need to treat the patient case reports from other institutions?
It's tough. Oh, so how do you balance if I'm understanding your question correctly, how do you balance sort of wanting to use these novel therapies at the bedside, knowing that research is still limited and it's really only based on case reports?
Yes. So should all the patients be in a randomized clinical trial? Should we go off of what CHOP is doing?
I don't think there's a right answer. We obviously we could do clinical trials in all of these, it would be great, but as we know, it's difficult to do in pediatric patients. It's difficult in rare diseases. These clinical trials are, again, multi-institutional, and they still have a hard time recruiting, especially like Norse fires. I mean, that's like the rarest of the rare. And so it really, again, takes like national efforts and a national leader to like do that. And obviously there's funding is a big issue too. But yeah, I mean, clinical trials are great, but for patients that also, I think the NMDA one is like out of Utah, so it's always like, do they need to be, I don't know, there's lots of difficulties also with getting our patients enrolled in clinical trials. Yeah, so it's kind of, I don't think there's a right or wrong answer, but I think at some point we're going to have to try to start using these therapies as long as, we think the prelim data is good, the safety data is good, in cases that are really refractory. I mean, we've seen these kids are getting really sick, they're getting worse. And like, I feel like sometimes we're just like, feel like such a loss and like want to try something new. And so I think, again, taking it case by case, I think it's probably the best we can do. And, having discussions with families, and just explaining like, we don't know if this is going to help. We hope it will, we don't know. And just making sure that they're aware of the potential risk and that it's still one of like the more novel agents that's limited.
So look like so from what you discussed, the first line treatment, whether it's an MDA receptor or MOG, it's an IVIG and steroids. It seems more like a maybe slightly different for second line alternative treatment option. Is that true?
Yes, compared to NMDA.
Yeah,
because I think that kind of goes to like MOG. I don't think we actually know exactly how it really contributes to disease, whereas in NMDA we know it's antibody mediated, and so we're reaching for B cell depleting therapies, which we think are most effective. But I think MOG we think has a little bit of a different pathophysiology than what a normal type of antibody mediated encephalitis does.
Yeah, so you mean for MS that you also could have antibody because MOG is mature oligodendrocytes. You have antibody and they attack the cells, leading to the oligodendrocyte death and demyelination.
Yes, I agree. And I think, unfortunately, studies with rituximab, what we used to use a lot, are not as effective. So we saw kids breaking through on rituximab. So it definitely historically was used more, but I think we still think that there's something else going on that needs a little bit more different treatment.
So do you have any case of those children eventually progress to MS?
For MOG? Usually not. No, we think it's actually quite different. Yeah, so usually not. Okay, so time for another case, switching gears a little bit, more challenging case, but I hope that this highlights a more common kind of diagnostic dilemma that we face in our complex inpatient cases of encephalitis. And then I'll highlight a little bit of our own research in terms of how we're starting to think more about expediting diagnosis and improving the diagnosis. So this is a 16-year-old with MPO ANCA vasculitis. She had a renal transplant, was on immunosuppression, and she was presenting with 6 weeks of headaches, worsening renal function, and hyponatremia. So not worried about this kid? Worried, yeah, we were worried too. Her MRI demonstrated hypothalamic, pituitary, and optic chiasm involvement. And so again, given her history of autoimmunity and immunosuppression, we were pretty concerned. And so recommended, in conjunction with many of our teams, a pretty broad infectious and inflammatory workup, as shown here. So this is a patient that literally got the entire workup. Her CSF did have a pleocytosis with elevated protein and low glucose. So this initially raised our concern for a possible infectious etiology. Yet broad infectious workup in the CSF and the serum were ultimately negative. Full body imaging was negative. Renal biopsy was negative for sort of an ANCA related relapse. We even went forward with doing a pituitary biopsy, which showed kind of non-specific inflammatory changes, but at the same time, kind of full targeted infectious workup in the pituitary was negative as well. As we were still doing workups and trying to figure out what to do next, kind of hemming and hawing, she actually started to clinically worsen. So she developed worsening headaches and expansion of her lesions on her MRI. And so we're kind of stuck asking, what should we do next? So does anyone have thoughts for additional diet? And maybe some of you guys cared for this patient, so you may know where I'm going with this, but any ideas for additional diagnostics? Should we just empirically treat her? What would we treat her with? Any thoughts? Great. I like where your head's at. I like that. But yeah, I mean, this is a tough case. There were, she negative workup really everywhere, and we're kind of like left with taking our best judgment and kind of thinking like, unlike the first case that was like, okay, we feel pretty confident this likely is autoimmune encephalitis. This is a little bit trickier. And in these situations, again, it's kind of like, do we, especially with her history of autoimmunity, but she's immunosuppressed. So it's kind of like, if we do want to treat her, do we actually escalate her immunotherapy for empiric treatment of sort of an inflammatory process? Or on the flip side, are we missing some bad infection? And should we actually de-escalate immunosuppression and broaden our antimicrobials? So I think this is a more common dilemma here than what we like. We did give her steroids. She got better, but then she got worse, unfortunately. And so, we brought the question of whether or not there was any additional testing that could have been done to better help us along this decision tree. One test that I didn't mention that was still pending at the time of all of this was her metagenomic next generation sequencing. And so most of you probably are becoming more and more familiar. I don't know if we have any ID docs in the room. No. You're probably becoming more and more familiar with metagenomic next generation sequencing. But in general, the pipeline is shown here. So we collect specimens. It can be blood, CSF, respiratory secretions, tissue. We extract the DNA and the RNA in the lab with very standard procedures. Sequencing libraries are then prepped by generation and amplification of double-stranded cDNA, then sequenced, and then all the sequencing reads are mapped to the human genome, which comprises the majority, in our case, the CSF, which is what we're most interested in. And so then when we're looking at this as an infectious disease assay, all the reads mapped to the human genome are actually removed, and the remaining reads are aligned to large databases of all known pathogens, viruses, pathogens including viruses, bacteria, parasites, fungus, and so then you ultimately get an output of potential pathogen hits. And so this really provides an unbiased, hypothesis-free approach that allows for detection of really sort of any pathogen and avoids the need for more targeted testing. So in her case, the NMGS was still pending, but ultimately it came back for trichondysplasia spinulosa-associated polyoma virus. So does anyone know what this virus is? Yeah, I still can't pronounce it. Does anyone? I wish, no ID docs in the room either to ask this question too. But yeah, a lot of head shaking. Turns out we didn't know what this was either, and whether or not it was truly causing her disease or if it was just an innocent bystander. Turns out the virus has caused rare dermatologic disorders in immunosuppressed patients. So it has been known to be pathogenic, but not previously known to cause neurologic disease. And so in order to confirm that this was truly pathogenic, the team performed additional investigations, including NMGS of her renal and her pituitary lesions, which showed abundant viral RNA, and then host transcriptomics, which I'll talk about in a second, and spatial transcriptomics further confirmed that this virus actually was pathogenic. And so ultimately, we went the other route, initiated cidofovir. The patient had clinical and radiographic improvement corresponding with declining viral titers. And so this is a case, an example of how NMGS can be really utilized in the appropriate setting and how ultimately it can change patient care. We get this question a lot, like, when should we order it? Should we be ordering this on every patient? I think probably people have different answers to that. ID docs may feel different than we feel, but I think definitely in these more complex cases where conventional testing is negative and clinical suspicion is high, like you're really worried that you could be missing a bug, especially if you're going to go forward with doing immunosuppression. You really want to be thinking about sending NIH. So I hope this case also illustrates how it can be really difficult to determine if a case is infectious or autoimmune, given there can be overlapping clinical phenotypes, and highlights how we really need to better diagnostic tools to differentiate these diseases, which ultimately could lead to more targeted treatment approaches and improved patient outcomes. Taking a step back, again, part of the reason why this can be so challenging is we are limited in our diagnostics. So when we think about the diagnosis of autoimmune encephalitis, we have, the clinical syndrome, clinical history, in conjunction with autoantibody panels, which have long turnaround times, and they're only available for known autoantibodies. So there's a really high likelihood of a false negative. And then in infectious encephalitis, we have our, historical conventional methods, targeted panels, and then NMGS, which I mentioned as an unbiased approach, but definitely has its limitations. Yeah.
Because this is something I've always wondered about, and you mentioned earlier on that sometimes that there's recently 2 patients in the unit, right? One of the things that I've noticed, and maybe this is totally my bias and perception, is that these patients tend to actually not necessarily always come in isolation, but they sometimes come in little clusters, and not huge clusters, but 2 or 3 in a row, and then nothing for months. And you present this here as if these are completely different entities. But I've often wondered, but infectious encephalitis, yes, you get an infection, so your brain is on fire. But autoimmune encephalitis, why all of a sudden does a 12-year-old get autoimmune encephalitis? And is it really so distinct, or you just showed us, I can't pronounce it and I don't remember it even, an infectious agent that I bet you nobody else in this room had ever heard about, minus maybe you and some of your colleagues. Like there is some an inciting infection that actually causes the autoimmune encephalitis, and we just don't know what that is yet.
I totally agree. I think when I think more about infectious encephalitis, I should clarify, I'm thinking like acute infection. We definitely know that there's post-viral cases of autoimmune encephalitis, like HSV1 definitely can trigger an NMDA encephalitis, but that can happen like weeks to months later. And so it's not necessarily in the acute period, but definitely, you bring up a good point, is this virus concurrently causing an immune-mediated inflammatory response, and should we still target that response in addition to treating with antivirals or antimicrobials? So I think more so thinking about like acute infection or like the rare fungal diseases, those types of things. But yeah, you bring up a good point. There could be some cross, maybe it's not this distinct.
I would just add that this idea of autoimmune diseases there be an etiological effect of infection as an etiology has been debated for over 100 years. There's data multiple kind of data sets that to support that idea. It's been very difficult to show causation because these tend to be kind of very anecdotal and not always generalizable when you look at large numbers of patients. But it's an idea that's been around for a long time and never really been proven or disproven.
But now we have so much more powerful testing technologies with all this next generation sequencing and even that, right? It's only known pathogens, but there's so much that we don't know. So I think that debate will not be done anytime soon, and we have different tools now.
No, I want to add this because the multiple sclerosis we have been studied so long. Only last year we found out that the EB virus associated increase, like 32-fold of
Yeah.
increase of the incidence. I mean, it's really viral mediated.
Yeah, definitely. He's mentioning EBV and the connection to MS. Yeah, definitely. And I do think, to your point also, and like how these cases come in clusters, we have a collaborator at Toronto Children's, and she recently emailed us and said, like, we have like 6 or 7 cases of NMDA all at once. She's like, there has to be something viral or something there. And so we're actually trying to get those samples and do NMGS to see if we can pick up on like a specific virus. It's actually cool because NMGS, you can look at like levels of like strains too, so you can look if there's like a specific strain of a certain herpes virus. So again, there's some more sophisticated things you can garner from NMGS, but yeah, definitely to your point, again, that kind of goes to like the environmental triggers, potentially viral triggers, but nothing outside of the HSV1 and the later onset of NMDA, nothing truly causative. Okay, so I've hemmed on this a lot, that it can cause kind of at the bedside these treatment dilemmas. And I highlighted one case, but we've had a lot of other cases. We have a case right now where we're like, is this infection or is this something inflammatory? Like, when do we pull the trigger on doing immunosuppression or doing more broad antimicrobials? So I'll spend just the last, let's see, I have 5 minutes. I'll try to do this in 5 minutes, talking about my specific area of research, where we're looking to actually harness the host immune response. So not looking at the pathogen data, but looking at the human RNA transcripts to see if that can help us better differentiate AE autoimmune from infectious encephalitis. So how do we do that? Again, we use the same NMGS pipeline, but the last step, instead of discarding the human reads, we actually leverage those and perform differential gene expression analyses to kind of assess for relative upregulation or downregulation of the different mRNA transcripts or gene expression levels between diseases. And so this allows us actually to directly interrogate the immune system and the immune response, as opposed to waiting on targeted antibody panels. So, we could hypothetically look at the host response and say, look, this has certain upregulation of genes that are characteristic of autoimmune, even though we don't have an antibody. It looks more autoimmune, or this is more characteristic of viral or infection. So maybe we should hold off on doing more chronic immunosuppression or more acute immunosuppression. This was our preliminary cohort that looked at a relatively large for CSF collection of antibody-mediated and viral encephalitis. This was big collaboration with Michael Wilson and his team, where we biobanked to really try to biobank as many CSF samples over the past year, or not year, past several years. And then ultimately we put the CSF through the host response pipeline, perform differential gene expression analysis looking at the autoimmune versus infection. Turns out we were able to detect some differences. So this is a heat map. You can see on the right the differentially expressed genes, and then it's broken down by antibody type, and then the viral encephalitis cases are in the neon green. And so you can see that if you kind of imagine that the NMDA cases look different than the other cases, and then there definitely appears to be more of a viral signature, and then GABA and LGI1, which are kind of adult onset autoimmune encephalitis, look a little bit more similar. There were many differentially expressed genes. So this is a volcano plot that looks at the number of differentially expressed genes. So each dot is a gene, and red dots are the ones that are significant. And so we see here that there were over 1,000 genes that were different between the autoimmune group and the infectious group. Over 800 were upregulated in infectious encephalitis, 500 were upregulated in autoimmune encephalitis. And this diving into the genes a little bit more, you can see that the top genes were actually very classic antiviral genes. So grade 1, IHG15, IF5, very, very classic sort of antiviral type 1 interferon genes. And then we saw enrichment of histone modification pathways and then the proteasome, which also kind of has a role in CD8 T cell responses and inflammation. So we thought this was pretty cool. We were seeing differences, and then they actually kind of biologically made sense. looking at the the upregulated genes in autoimmune encephalitis, we actually were seeing more kind of neuronal and synaptic genes, including ion channels, synaptic adhesion molecules. And so we didn't necessarily see like classic immune genes, but the neuronal dysfunction gene, synaptic disruption probably actually is more relevant to the biology of autoimmune encephalitis that targets more kind of the neuronal cell surface and synaptic proteins. So this is, again, just preliminary data showing that CSF transcriptomics in this pilot study, we're able to differentiate between autoimmune and infectious encephalitis. The genes in the viral encephalitis cohort were very consistent, again, with type 1 interferons, innate immune response, but obviously we need repeat analysis on larger validation cohorts to confirm the signature kind of before application to unknown cases, which ultimately would be the goal. Shameless plug, any kid getting an LP for concern for a neuroinflammatory disorder, you can email me, email our research coordinator with an MRI and a one-liner for consideration of research enrollment. So we're doing NMGS, host response, novel antibody discovery, and then trying to build out our single cell sequencing pipeline as well with Aaron Bodansky and the PICU. All right, so key take-home points, just to summarize. Anti-NMDA, most common pediatric encephalitis. We know earlier recognition and immunotherapy improves outcomes, so really important to recognize these cases early. Other clues, oral buccal dyskinesia, psychiatric symptoms, and normal brain MRIs. MOGAD is not MS. We know it's a distinct demyelinating disease that's actually quite different. Always check a serum MOG in cases of ADEM, and then predicting relapse remains really an active area of research. And then lastly, CSF NMGS is a useful tool for pathogen detection, particularly if conventional testing is negative and clinical suspicion is high, like in immunocompromised patients. And then the host response is kind of emerging technology that hopefully will also be able to help aid in diagnosis of these more complicated cases. And if you ever have questions, concerns, you don't hesitate to give us a call, email me. We're always happy to get involved in our inpatient cases. Big thank you to Michael Wilson and the entire Wilson lab, as well as all the collaborators across the country who've sent us samples. And then my clinical mentors and our sort of MS neuroimmunology group here, Emmanuel, Carla, Akash over at Oakland, and then Heather, who's been an amazing career mentor. All right, how'd I do with time? 3 minutes left. So thank you so much. I really appreciate your time. Take any more questions?
Super interesting. Thank you so much for this great talk. I was curious, connecting back to what Matt was talking about in terms of like we're using, small sample sizes for these kids because it's a rare disease. Also, don't totally know whether or not things are working or not, like, these, novel agents. But you are at the end of your talk you were talking about these new diagnostics, so using transcriptomics, et cetera, to do the diagnostic. Is there any possibility you could track them for mechanistically being able to say, is this new novel agent helping or not helping? And could that then inform therapy for other kids around the country?
We have in rare cases, the problem is like you actually have to get the CSF. It takes a lot of logistical maneuvering. Like you have to get the CSF pre-treatment, then you have to treat, and then you have to be comfortable getting another tap. And that second tap, we don't always do if kids are getting better. So obviously, ideally, it'd be great. We have a patient, they have elevated IL-6 in their CSF. We treat them, and then that goes down. There have been a few adult patients that I've actually worked with, and we published on this a couple of case reports that have shown decreases in specific cytokine levels after initiation of anakinra, which is an IL-1 blocker. So definitely something that can be done, but just in our pediatric patients, the multiple taps, especially if they're getting better, we don't always do. But I think that's a great idea.